हाँ हाँ चलाइए ना, आवाज नहीं आ रहा है।
रवि जी साउंड जा रहा है? चलिए ठीक है, चलने दीजिए। मैम आएंगी तो वहीं पे बैठा कर फोकस कर दीजिएगा। ठीक। अपने हमारे एक मिनट।
The first episode is in your 20s, but it can very well start in your midlife, 35 to 40 years. So it is more common in unmarried that was have other and it has a mean duration of about 4 to 6 months and it may last 8 months. And it is wanting depression if it is lasted single episode is lasted beyond 2 years. It is usually precipitated following the psychosocial stressor like failure, death, childbirth, but this may not always be the case. It can also be so the onset is usually insidious or acute, or it can even begin abruptly. And as we have already talked about the duration, the course is variable. The interepisodic period can be absolutely normal. There can be some deficiencies from your premorbid self, and there can also be complete remission of the episode. There can be a partial remission, and origin. So, right from the genetics, the family history, as well as the psychological or the psychosocial aspects the neurobiological correlates pertaining to the neurotransmitters, the neurohormonal axis, the neuroanatomical correlates also, and we will be talking about all of that as well. When we talk about the genetics, depression is for monozygotic twins and 20% for dizygotic twins. It has a polygenic and then there is the gene environment interaction. Many a times it so happens that although there is genetic loading, but because of the environment you didn't have depression, or maybe there was no gene, but because of the environment, most amount of ground is the monoamine theory. That is a deficiency of serotonin. What is depression, and this is the theory that we. 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 This is the the where when we are faced with the same stressor again and again and again, we kind of give up. We sort of turn into this situation and stress substrates for stress response. The most well established are the way they perceive the external as well as internal stressors, that is altered, which kind of aids or causes. Now coming to the aspects, each one now areas of key symptoms in depression, like the persistent a lack of interest is difficulty in concentration and attention. So, difficulty in focusing or maintaining your concentration on the task. About the environment or others, that is helplessness. So this is the Beck's triad, which is also the backbone of the cognitive theory of depression. So the way we perceive our surroundings changes with depression, and it is a vice versa relationship. And thereafter, there can be ideas of self-harm and suicide. There can be for depression. Duration minimum of 2 weeks. Less than 2 weeks. See, suppose I have a fight with a family member, or I have an exam and I'm not feeling so good for a day. That does not make me depressed. At least a persistent and pervasive change for at least 2 weeks is what is needed. Anything, but that is not warranted recognized medical condition unless it is there for 2 weeks, it is causing some socio-occupational dysfunction, and it is characterized by all of these which are present for a sustained period of time. Other than this, there are some somatic or vegetative symptoms in depression. These are anhedonia. Then there can be early morning awakening, that is more than 2 hours before your usual time of waking up. That is classically seen in depression. The mood worsening of mood symptoms are there in the morning. There can be loss of appetite, significant weight loss of about more than 5% in the past month, in 1 month. Then loss of libido or psychomotor retardation or agitation. What we mean by psychomotor retardation or agitation is a very profound lethargy or evolution, if you are able to understand that term. And then psychomotor agitation, मतलब बहुत बेचैनी है. The patient is very restless. He is unable to sit still. So disturbance in the psychomotor activity is also seen in depression, and it is one of the somatic symptoms. So now let us talk about the other types of symptoms that we see in depression. There can be anxiety symptoms also associated with depression, which will include worry, apprehension, a feeling of panic, restlessness. There can be some somatic symptoms जैसे headache हो रहा है, abdominal pains हो रहे हैं. Then depersonalization and derealization symptoms. That is, you don't feel attached to your surroundings. You feel like, oh my God, मतलब the world has changed, or it feels a little plastic, as if it was not real. So these are anxiety symptoms which can very well be a part of depression. Then there are some pseudo-dementia symptoms. A subjective feeling of forgetfulness or slowing of mental functions can be seen. These are not true dementia symptoms, but pseudo-dementia symptoms which are a part of the depressive spectrum. Psychomotor symptoms, as we have already talked about, like retardation, agitation, as well as more sinister form of psychomotor retardation, which is catatonia. Thereafter, psychotic symptoms can be there. There can be delusions which are characteristically seen in depression include those of nihilism or delusion of sin or guilt. So, and then there can also be hallucinations which can be associated in that case, provided these symptoms are present, we consider it a depression of a more severe kind. Then there can be cognitive problems. What happens is, see, I talk a lot about cognitions when I'm talking about depression. So what happens is, cognition matlab the way you perceive things, the way you perceive an event, that is what changes when you're depressed. So there can be selective abstraction. Suppose 10 good things happen to you and one bad thing happens to you, but you only are able to focus on the bad event. You're not able to see all the good things that you did all day. So that is a cognitive distortion. Means, you know, you're focusing more cognitively on something that was bad, which can exacerbate depression. So these are the things. Other than that, an emergency sign is presence of suicidal behavior or catatonia. In those cases, we prefer IPD management. Okay, IPD, that is, we'll admit the patient and then manage, see where it goes from there. Now, the clinical variants. So, depression can be n number of types. Okay, I have listed down the types here. Reactive depression means it's a reaction to something that is going on in your life. Okay, so separation from a spouse or death of your parents or spouse or a loved one, sudden loss of employment, provided that depression occurs in the context of this background due to a stressor or a precipitating factor, we call it reactive depression, and it usually carries a good prognosis. Then there is endogenous depression, wherein these are because of internal biological factors. There may be no stress in the environment, but it is your biochemicals in your brain which are causing depression. That is called as endogenous depression. Then there is agitated depression, that is psychomotor agitation is wherein psychomotor agitation is prominent and is more seen in the elderly patients. Then there is retarded depression, when there is profound lethargy. Patient will not feel like getting up, doing his daily chores. So this is seen in retarded depression. Thereafter, there is psychotic depression, like we talked about. The hallucinations and the delusions will be prominent in these cases. There can even be depressive stupor, wherein there is catatonia along with depression. So the motor symptoms are more prominent there. Then atypical depression. Now here, when we talked about the derangements in appetite and sleep specifically. So in atypical depression, usually depression is associated, the classical depression, with decreased appetite,
and decreased sleep. But in atypical depression, there are reverse vegetative symptoms. So there can be a reactivity of mood, okay, so which may be perceived as mood swings to somebody who's there. There'll be a lot of rejection sensitivity. So small, trivial critical comments may incite a large magnitude of reaction. Then there can be reverse vegetative signs like hyperphagia. So the patient will eat more, binge eating may be there. And then there is hypersexuality and hypersomnia. So this is atypical depression. We need to be very cautious. And thereafter, chronic depression, wherein depressive symptoms will last for more than 2 years. So other types of depression can be a recurrent depressive disorder, that is more than one episode of depression. If there are more than 2 depressive episodes and in each episode it fills the criteria for a mild, moderate or severe depressive episode, we call it a recurrent depressive disorder. Thereafter, there is a dysthymic disorder wherein persistent depressive symptoms are present for days, for most days, and the duration is more than 2 years. So it is a subsyndromal kind of depression, wherein there is low mood for most of the days, and the patient will feel low, but he will never fulfill the proper criteria for a depressive disorder. So all the cardinal symptoms and all the boxes will not be ticked. But there is a low mood, there is a particular dysfunction, never reaching the threshold to call it depression. And when a depressive disorder occurs on a course of dysthymia, so the patient was already feeling low, like suddenly some stressor happened, or even in the absence of a stressor, the patient dips down further. So much so that it warrants a diagnosis of depression. So in that case, it is called as a double depression. In a special population, depression can have special presentation. The symptoms may vary. So in children, it may present as school refusal. They will refuse to go to school. There may be more somatic complaints, more of headache, more of abdominal pain, and limbs may hurt, things like that. And there may be excessive clinginess to parents, and there may be academic decline. So we also need to assess our patients very holistically. You need to, whoever you are looking at, you need to see in a very holistic fashion. How is he performing in school, at home? How is he behaving in general? Because the signs, the red flags can be there in any domain. Now, in adolescence, depression may present with poor academic performance. There may be substance use. There may be sexual promiscuity and truancy, that is lying to get out of school or missing school. So these things may be there. Thereafter, in the older populations, in older populations, it is typically called as melancholic depression, because in older populations, the patients will not typically come and complain of low mood. They will come to you more with somatic complaints. And ये cognitive slowing, मैं ये नहीं कर पा रही हूँ, मैं कोई calculations नहीं कर पा रही हूँ, मैं चीजें भूल जा रही हूँ. These may be the complaints, but when you dig deeper, you may find that there has been low mood also. There have been vegetative symptoms also. And especially when it is correlated to retirement, when it is called as empty nest syndrome. Empty nest because after a certain age, when all your children are working and they've all moved out, it was a concept typically developed in the West. Because after a point of time, when all your children go to college and it's just you and your spouse alone in your home, so that may be a triggering factor for depression. And in those cases, it was typically called as empty nest syndrome. And it is characterized by loss of functional ability, concurrent physical illness, and social isolation. Thereafter, there can be masked depression and atypical depression that we've already talked about. So these are some other complex terminologies, but let us not delve into that because there are more interesting things on the way. So coming to the management part. Management of depression will rely heavily on how good a history we've taken, the examination of the patient, the general survey, the general physical health of the patient, the systemic examination, as well as the mental state examination. So, and after that, we also need to rule out secondary medical causes of depression. So there are a lot of illnesses, medical illnesses, which are associated with depression. Example is diabetes, then your fibromyalgias and pain syndromes can be associated. Cancers may cause depression, and so there are a lot of medical causes for depression which also need to be ruled out. And then we need to decide where to treat the patient. We can treat them in the OPD basis or admit them and treat them in the IPD. Now, workup of depression will also need certain labs or diagnostic tests, which will include a complete hemogram, B12 and folate levels, a thyroid profile, a CT or MRI to rule out any organic causes, whether there is an actual lesion in the brain which may be causing depressive symptoms. We also need to get a EEG and urine drug screen to rule out any substance use. Depression can also be secondary to substance use, so we need to rule that out. Thereafter, we apply screening questionnaires. There are some screening instruments like Beck's Depression Inventory or General Health Questionnaires are there. Then Hospital Anxiety and Depression Scale is there. Then, so these are self-reported screening tools, whereas some are physician-rated scales, like the Montgomery and Asberg Depression Scale and Hamilton Scale. So we will apply scales so that we are able to quantify the amount of depression and then further with treatment how much it is resolving. So it will help us to see the progression of depression. So, and thereafter, modalities of treatment, they can be pharmacological as well as non-pharmacological. So the first two the charts in the table, the antidepressants and adjunctive medications, these are the pharmacological management that we do. In antidepressants, we can use first generation antidepressants, which include the tricyclic antidepressants and the MAO inhibitors. And then the second generation antidepressants, which are more commonly and more widely used these days because of their lesser side effect profile and better tolerability. So the selective serotonin reuptake inhibitor and the serotonin norepinephrine reuptake inhibitors. And adjunctive medications that can be used to augment or to add to their action can be lithium, thyroid extracts, buspirone, mirtazapine, bupropion, even beta blockers, benzodiazepines, and anticonvulsants, even magnesium. Magnesium is a known adjunctive medication for depression, which helps tide over severe depressions. In treatment-resistant depressions, we often add NAT-self. And then other than that, phototherapy or bright light therapy is something that you might have heard of, just in passing over social media or something. So bright light therapy can be given. Then repetitive transcranial magnetic stimulation is another modality of treatment which may be used. ECT, as we all know, electroconvulsive therapy, something that psychiatry is very notoriously known for. So it is actually a very life-saving procedure, especially in emergency cases like catatonia, in suicide or refractory depression, or those with psychotic symptoms, or in pregnancy where the drugs that we can use are very limited. In those cases, ECT comes in very handy. Less side effects, no side effects actually, almost, and very, very quick response. So thereafter, the psychosocial treatment, which can include psychoeducation, counseling, and different modalities of psychotherapies that are used. For example, there is individual CBT. CBT means cognitive behavior therapy, wherein we work on the cognitions. What are the thoughts and perceptions, how we perceive events that lead to causation of depression or which may exacerbate your depression. So here we kind of modify how we think. Then there is interpersonal therapy between two people. There can be marital therapy, couples therapy. Then there is something called as behavioral activation. I will not go into the details because they may be very, redundant and boring for you. So just know the names, just know what all is out there and what all can be done. These are something, at least, you will not be clueless. Now, when treating depression, we use a stepwise approach in treatment. So the step one, it starts from the bottom of the slide. We use the least intrusive method and the most efficacious method at the same time to bring out the best results. So in all the known and suspected presentations of depression, we use assessment, support, psychoeducation, active monitoring, and further referral for assessment and interventions. Thereafter, in step 2, if there is persistent sub-threshold depressive symptoms, like dysthymia, and mild to moderate depression, in those cases, we use low-intensity psychological and psychosocial interventions, and medication and referral for further assessment and interventions. So thereafter, we go to step 3, provided there is a persistent subthreshold depressive symptoms or mild to moderate depression with inadequate response to initial intervention. So we have tried first and second steps, and there was not response to those steps, or the depression is more severe in nature. Okay, so it is moderate or severe depression. In those cases, we use medication along with very high intensity psychological interventions. We often use combined treatments. We use collaborative care and further referral for assessment and interventions. And provided that there is a severe and complex depression, like I talked about, there is suicidality, there is severe resistance, or there is a risk to life, the patient is suicidal, catatonic, or there is a severe self-neglect. In those cases, along with medication and psychological interventions, we also use the electroconvulsive therapy, crisis services, and combined treatment of multi-professional, and we prefer inpatient care in these patients. So this is the stepwise approach in treatment that we follow. Now, the phases of treatment in major depression. So once depression hits you, once you start your treatment, the 6 to 12 weeks period, the first 6 to 12 weeks is considered as the acute phase. Okay, so here our prime target is to reduce the symptoms of depression and bring it down to a remission stage. And thereafter, the continuation treatment, which is given for the next 4 to 9 months, that is given to prevent a relapse. So this also corroborates with the fact that the usual length of a treated depressive episode is hardly 3 months. Untreated depression may go up to 8 months, up to 1 year, but when treated within 3 months, the episodes will go into a remission. But we need to give a continuation therapy for the next 4 to 9 months so that the risk of relapse is reduced. And provided that despite of having taken up acute continuation phase also, if there is a recurrence or if there is a higher risk of recurrence because of certain factors in the patient, we may give maintenance treatment which may last for 1 or more years. Now, the mechanism of action of antidepressants, this is something that I want to teach you because of a lot of, myths in the market, I would say. So, neurotransmitter, how the antidepressants act basically. So see, what happens in depression is that, like we talked about, your neurotransmitters, the serotonin, the dopamine, the norepinephrine, they are lesser in number. So what will your, you know the relationship between neurotransmitters and receptors. So if the neurotransmitters are less, there is upregulation of receptors, the number of receptors will increase so that even a small trivial amount of neurotransmitter that is there that can be detected. So there is a high sensitivity and there is an upregulation of receptors. Now what happens is when we give the antidepressant to the patient, it will block the reuptake pump. It will cause more neurotransmitters to be there in the synapse. When we initially give the antidepressants, the amount of neurotransmitter in the synapse suddenly goes up. So for the first 1 to 2 weeks, there may be some experience of side effects of depression, side effects of antidepressants, which may include some nausea, vomiting, maybe restlessness, increased anxiety, which is why we always give a small dose of benzodiazepines in the initial phase to tide over this. Now what happens is after 1 to 2 weeks, this amount of neurotransmitters and the number of receptors, they will come into perfect sync. Okay, so now the side effects are less, the tolerability has already developed, and now the antidepressants will start to show their action. So for the first 1 to 2 weeks, there may be some side effects which are which with the help of your physician you can tide over, and thereafter this 2 weeks period is very essential so that this neurotransmitter and receptors can come into sync with each other, and thereafter the antidepressants can start to show their benefits. Now, the course and prognosis of depression, most treated episodes will last only about 3 months as compared to 8 months to 1 year of an untreated depressive episode. And 25% of patients will experience a recurrence of major depressive disorder in the first 6 months. And about 30 to 50% will experience a recurrence in about 2 years. Now, these figures are much lesser. The incidence of relapse that is happening, that is much lower in patients who continue prophylactic treatment. So the continuation phase of treatment is very important, which is why we always tell the patient that the treatment may last longer, but it is for your own good so that you don't relapse into the another depressive episode. There are some common myths about depression in the market. So let us delve into that and let us try to understand depression from a more layman point of view. So a myth is that depression is not a real illness, but it is not a fact. The fact is that depression is a recognized mental health condition and has been certified by WHO. So it is not that depression is not a real illness or that it is just in your head. It is an actual condition as real as hypertension or diabetes or typhoid. Depression is as real as that. Now, there is another myth that it is obvious when someone is depressed because they're depressed people will look sad, but that is not true. There is something called as depressive smile. So a patient of depression may be on the inside, he may not be feeling so good, but on the outside they may also keep a smile. So it is an internal struggle and it can be very well hidden. So remember that. Now, another myth is that antidepressants are addictive, and this is something that I hear. So, antidepressants are not addictive. We need to give them for longer periods of time, for up to about 6 months after remission of an episode, to reduce the risk of a relapse. And stopping the medicine suddenly can cause discontinuation syndrome. So that is why it should be done under supervision. But that is not because of addiction. That is not a withdrawal reaction. It is discontinuation syndrome because of sudden abrupt withdrawal. It is like serotonin or dopamine or norepinephrine जो है उसके साथ आप खेल रहे हो अगर आप ऐसे कर रहे हो तो. So remember that it is not an addiction. Now another myth is that depression is just a negative thinking. It is normal as we age and it will pass. So that is also not true. Depression is a recognized illness with complex underlying neurobiological abnormalities, and it needs treatment, and it is treatable as well. Untreated depression can cause physical, psychological issues and interfere with your functioning, and it is not just negative thinking that you can snap out of. So in conclusion, I think the take-home message will be that depression is a recognized mental illness. It consists of complex neurobiological correlates, and it can impact your thought, behavior, and even your physical health. However, it is very treatable, and with appropriate pharmacological and non-pharmacological interventions, we can tackle it. Depending on the severity, we decide whether only non-pharmacological interventions are sufficient, or we also need to add medications to that. That will depend. That is something that is tailored. Thereafter, we give long-term medications in depression, no doubt, but that is done to prevent a relapse into another episode. And the discontinuation of the medicines, they must be done under supervision. So that is that ends my presentation. Thank you. And in the end, I would like you to read this picture and take it home with you. That depression is not a choice. It is not something that you can snap out of, and it is not merely attention seeking. Okay, it's a real illness, and that's all from me. Thank you.